So I'm Simon Gilbody. I'm a psychiatrist, cognitive behaviour therapist by clinical background, but the science I do is largely population science and epidemiology. And I'm Professor of Psychological Medicine at the University of York, and I'm also Director of the UKRI Closing the Gap Network.
Okay, I'm Gordon Johnston. I'm a peer researcher. I have lived experience of bipolar, and I've been involved in the network since the launch event as a representative with lived experience. Yeah, I mean, clearly the pandemic and the lockdown response has affected everyone in society, but I think it's becoming clearer as we do more and more research that really what's happened is the existing inequalities in society have largely been exacerbated. So for people with severe mental illness, there has been the isolation and loneliness of having to self-isolate has been a big impact. The other thing for a lot of people is that routine and self-management techniques that we use to keep ourselves well quite often involve things like being out and about, going to support groups, meeting with other people, basically all of the things we've not been able to do through the pandemic. So that clearly has had a kind of undue impact on a lot of people's mental health, in that many of the services and the supports and the interaction with other people that we would normally be used to as part of our day-to-day life has pretty much disappeared over the last, almost a year for some people.
So Gordon raises some really important points there, and I guess that speaks to the broader lessons of the pandemic. So we know that COVID, as it's affected the population in this country, it's disproportionately affected some of the most socially disadvantaged groups in the population. And it's amplified the health inequalities that Gordon has spoken of. So it's not an equal opportunities thing, COVID. So all those things that we know about broader society that COVID has taught us are amplified several fold amongst people with the most severe forms of mental ill health. The NHS completely changed and shifted its focus to the immediate management of COVID. So lots of services went online as well. So, which is great if you feel tech savvy and you can keep up with things. But it does mean a lot of people potentially get left behind. So one of the things that we were concerned with, and people who were experts by experience told us this, was that the digital divide that exists in certain sections of society, that might become amplified under COVID as well. So if you're not so comfortable with technology, or you don't have the financial resources to access large data packages, or fancy phones or digital devices, then you're excluded from big swathes of what happens in the NHS under COVID.
Yeah, I mean, digital divide is such a massive issue for so many people, because the kind of moves to services being delivered largely online was happening very slowly over time anyway. When COVID hit, that just accelerated beyond all belief. And big systems like the NHS are traditionally not good at changing quickly, but they have done so during COVID, and that's had a massive impact on a lot of people.
This digital divide is really important. So we're working really closely with people who understand how you might improve digital access and digital literacy. And they've not really thought about the issues for people who use mental health services before. So our research and the partnerships that we've formed, really great partnership with Good Things Foundation, who a great social enterprise, who are really interested in ensuring that digital divide doesn't become further entrenched. They've thought about how their work might speak to people who use mental health services, and that's come out of the work that we've done around COVID. So those are just some examples about understanding the nature of the issue, and then going on to see how you can mitigate the impacts of COVID. So when we started the Closing the Gap network, we already had a brilliant group of almost 10,000 people who were members of the Closing the Gap cohort. That meant that we had this brilliant resource already in place when COVID hit, and that enabled us to be quite agile and to think, well, what are the important pressing questions for our population? And we spent a bit of time thinking about what the issues might be, and we recruited a group of people within the cohort. We very quickly received funding from the National Institute for Health Research and from UKRI to set up a new project within the Closing the Gap cohort that was very neatly called OWLS, and I claim no credit for the acronym, which stands for Optimising Wellbeing During Lockdown Study. We approached a few hundred people within our cohort and asked them if they wanted to work with us to try and understand the impacts of the pandemic, the restrictions, and they also gave us permission to come back to them, ask questions over time. So we've been able to track how the COVID pandemic has impacted, and we've gone back 2 or 3 times now. We've got aspirations to track people over time, and we thought this was a really important complement because there have been loads of really important surveys that have taken place during COVID. So some very clever people, researchers, very quickly set up online data collection systems to try and track the impact of COVID in the broader population. And our concern is that people with the most severe forms of mental ill health don't necessarily sign up to these voluntary population surveys. So we thought it was really important that the voice of people with severe mental ill health was heard in terms of thinking about the pandemic and how that's impacted on certain sections of the population. So we very much saw that as a complement to these important, very large population surveys, but which were not necessarily applicable, realisable to the experiences of people with severe mental ill health.
So there are different levels of involvement within the OWL study. I mean, I'm one of the co-investigators on the study, so I'm bringing that perspective along with working along with colleagues from academic backgrounds, from NHS backgrounds, so that we bring those different aspects to design. We also have what we call the LEAP, the Lived Experience Advisory Panel, and questions for the study, for example, are run past that panel. So they are coming up with some of the questions. They're coming up with the issues that lead to the questions from their lived experience. We're testing surveys out with them first. Has been very useful in just helping to redesign things and design things properly in the first place.
Good question. So we don't do research just for the sake of it, just to satisfy our own curiosity, although this is a fascinating area in which to work. But I guess we're driven by the aspiration that our work is going to have some impact in some way. So at its simplest level, we're not going to cure all the health problems associated with COVID. We're not going to sort out the mental health of the whole population of people who use mental health services. However, there's a really important point that in order to try to address some of the inequalities and the problems that we thought pre-existed, it's really important that you describe and understand the nature of the problem. Otherwise, you're just shooting in the dark, really. So I would say it's a necessary but not sufficient condition, trying to describe and understand the nature of the problem. But it gives you a really good starting point. So we've understood quite a lot about how health risk behaviours have changed. We've understood how levels of loneliness have potentially increased for this population. We understand a little bit more about how good some people are at accessing digital technology and information, but also how excluded some people are. So we understand the nature of the problem much more now, and I'd say that that's the first step on a road to trying to mitigate the impacts of COVID. So first understanding, then mitigating. So one of the great things about the networks is that we all speak to each other on a monthly, quarterly, 6-monthly basis. So and there's quite a lot of overlap between what we do, and so the networks don't live in silos, and so we look wherever we can for opportunities to collaborate and bring different perspectives to important problems for people who use mental health services. So the establishment of the networks really has kick-started lots and lots of research and lots of interdisciplinary discussions in certain areas. So we were able to tap into that when a new problem arose, loneliness amongst people with severe mental ill health during the pandemic and during the lockdown. And that wouldn't have probably happened if those networks hadn't have been in place and we didn't have that infrastructure and those conversations weren't taking place.
I was just agreeing very much with Simon, and a lot of this was about those pre-existing relationships and the trust that's built up over a number of years. You know, it's always easier to work with a group of people for the second, the third, the fourth time when you've got to know each other a bit. You know how each other work. You can play the roles you play in projects. It's always far easier to do that than it is to set up something from scratch, and particularly when we're working under the conditions we've all had to work under over the last year.
There's also the having a series of people from different backgrounds and perspectives who are working together already, and they can bring together that collective expertise, those synergies, really quite quickly to and turn their expertise to new problems as they emerge. So having a research infrastructure and a network in place allowed us to again move very quickly because those conversations were already taking place. That we've already working with different academic disciplines, with voluntary and community sector organisations, and we already had established the things that Gordon has spoken of that enabled the mechanisms of co-production to work very smoothly.